Welcome back to Roadmap to Residency. In this video, we are going to walk through high-yield test-taking strategies for sepsis and septic shock on the United States Medical Licensing Examination Step 3. This is one of the most heavily tested topics on the exam, and the questions reward a calm, repeatable approach more than raw memorization. Our goal today is not to teach you all of critical care. Our goal is to show you how sepsis questions are written, how to recognize the patterns in the STEM, and how to choose the best next step under time pressure. Lean on your trusted board review materials, your question bank, and a reliable management reference for the underlying content. Here, we focus on strategy. Let us get started. Here is our plan. First, we will define the sepsis syndrome the way the exam expects you to recognize it, including the newest consensus criteria and the quick bedside screening score. Second, we will move through the management that the test cares about most, namely early fluids, the timing of antibiotics, source control, and choosing the right blood pressure medication when fluids are not enough. Third, and this is the heart of the video, we will master the question stems. You will recognize the common patterns and learn a repeatable strategy to find the best next step. Throughout, remember to pair this video with your trusted board review book, your question bank, and a solid management reference. This video teaches you how to apply that knowledge strategically when it counts. Let us start with the big picture, because almost every sepsis question begins by asking you to recognize that you are even looking at sepsis. There are two screening tools the exam loves. The first is the quick bedside score. It rewards you for noticing three things at the bedside: a low blood pressure, a fast respiratory rate, and altered mental status. When the STEM gives you a confused patient breathing fast with a soft pressure, that is the writer waving a flag at you. Two or more of those findings should push you toward urgent action rather than reassurance. The second tool is the consensus definition itself. The newest definition calls sepsis a life-threatening organ dysfunction caused by a dysregulated response to infection. In plain terms, the exam wants you to pair a clear infection with evidence that organs are failing, such as a rising creatinine, a climbing lactate, a falling platelet count, or new confusion. Septic shock is the more severe layer. That is the patient who still needs blood pressure medication to keep the pressure up, and who has a high lactate even after you have given enough fluids. Learning to spot that progression, from infection to organ dysfunction to shock, is often the entire point of the question. Now let us talk about what to actually do, because the exam tests the sequence of early management constantly. Think of the first hour in 3 moves. First, draw blood cultures before you give antibiotics whenever you reasonably can, and check a lactate level. A high lactate is a quiet alarm that tells you the tissues are not getting enough oxygen, and that the patient is sicker than they may appear. Second, give broad antibiotics quickly and start generous, balanced crystalloid fluids for the patient who is hypotensive or who has a high lactate. Both of these belong in that first hour, and the exam will punish you for delaying either one. Third, reassess. After fluids, look again at the blood pressure and the perfusion. If the pressure stays low despite adequate fluids, that is septic shock, and the correct next step is a blood pressure medication, not pouring in liter after liter of fluid. Here is your takeaway for this slide: cultures and lactate, then antibiotics and fluids fast, then reassess and add a pressor if the pressure stays low. Hold on to that rhythm because it answers a remarkable number of questions. A lot of people ask how Step 3 differs from Step 2 clinical knowledge. Step 2, clinical knowledge, is taken during medical school, and it strongly influences where you match for residency, so that score carries real weight for your application. Its questions center on diagnosis and the clinical knowledge expected of a graduating student, and it is a single-day, multiple-choice exam. Step 3 is different. You take it during residency when you are already practicing medicine every day. It is required for your full, unrestricted license, and it leans much harder into patient management, continued care, and the skills of practicing independently. It runs over 2 days, and it adds the computer-based case simulations that Step 2 clinical knowledge does not have. In short, Step 2 clinical knowledge asks what is going on, while Step 3 asks what you are going to do about it over time. Now we reach the part where the patient is still hypertensive, even after good fluids, which means we are in septic shock and we need a blood pressure medication. The single most testable fact here is the first-line agent. Norepinephrine is the first-choice pressor in septic shock, and it is the answer the exam wants almost every single time fluids alone are not enough. It works mainly by tightening the blood vessels to raise the pressure, with only a modest effect on heart rate. So when a STEM describes a patient who stays hypertensive after adequate fluids and asks which medication to start, your default pick is norepinephrine. Be careful with dopamine, which is a classic trap choice because it causes more abnormal heart rhythms. Now, what if one drug is not holding the pressure? The classic next move is to add vasopressin as the second agent. The exam loves this exact sequence. Start norepinephrine, then add vasopressin when a single drug is not enough. And keep one more idea in your back pocket. For shock that will not respond to fluids and pressors, think about relative adrenal insufficiency and the role of a stress dose steroid. So watch for the STEM that keeps escalating the dose and then asks what to add next. The order is the answer. Before we hit the practice questions, here is the 4-step rhythm that works on almost every sepsis item. First, read the last line of the question first. The final sentence tells you what is actually being asked. The next best step, the best initial test, and the first medication to start are completely different questions, even for the very same patient, and you want to know which one you are answering before you wade through the STEM. Second, stage the patient. Decide quickly where they sit on the spectrum. Is this an infection alone? Is this sepsis with organs starting to fail? Or is this full septic shock that needs a blood pressure medication? The stage points you straight to the right next step. Third, predict the answer before you peek at the choices. Walk the early management order in your head, namely cultures and lactate, then antibiotics and fluids, then reassess and add a pressor and predict the missing step. If you already have an answer in mind, the attractive wrong options cannot pull you off course. Fourth, eliminate by mechanism. Cross out the answer that delays care, the test that wastes precious time in a crashing patient, and the antibiotic-only answer when a drainable source or an infected line is hiding in the STEM. Keep this rhythm in your head and watch how it plays out in the questions that follow. Let us put the strategy to work. Here is our first practice question, written to test whether you can recognize sepsis and choose the very first move. A 70-year-old woman is brought in from a nursing home for confusion that started today. She has had a productive cough and fever for 2 days. Her temperature is high, her heart rate is fast, her blood pressure is 85/50, and she is breathing 26 times per minute. She is drowsy and disoriented, and a chest film shows a new lower lobe pneumonia. The question asks for the most appropriate immediate next step. Your choices are: draw blood cultures and a lactate, then give fluids and antibiotics. Order a chest-computed tomography scan before treatment. Start a blood pressure medication right away, or give a fever-reducing medication and admit for observation. Read that last line, stage the patient, and predict your answer before we walk through it together on the next slide. Here is the walkthrough. Spot the pattern first. We have a clear infection, the new pneumonia, and we have several danger signs at the bedside, namely altered mental status, fast breathing, and a low blood pressure. When you see 2 or more of those bedside danger signs along with an infection, you are looking at sepsis, and that soft blood pressure is pushing towards shock. Now apply the rule. The first hour of sepsis care is a bundle, not a single act. You draw blood cultures and a lactate, and then you give fluids and broad antibiotics quickly. Choice A captures that entire opening sequence, so it is the move. Finally, eliminate the wrong choices. Choice B, the chest scan, only delays treatment when you already know the diagnosis from the plain film and the picture is clear. Choice C, starting a blood pressure medication right away, jumps the gun. The pressor comes only after fluids have failed to lift the pressure, not as your first action. Choice D, giving a fever-reducing medication and simply observing, treats the thermometer and ignores the sepsis in front of you. So the correct answer is A. Notice the strategy at work. We recognized the syndrome, we recalled the first hour bundle, and we eliminated every choice that delayed real treatment. Here is our second practice question, and it tests one of the highest yield traps in all of sepsis, the difference between antibiotics and source control. A 55-year-old man has had fever and worsening right-sided flank pain for 3 days. He looks unwell with a fast heart rate and a blood pressure of 90/60. Importantly, he already received broad antibiotics and 2 liters of fluid 2 hours ago, yet he is still febrile and his pressure has not improved. Imaging shows a blocked stone in the right ureter with a swollen, infected kidney sitting behind it. The question asks for the most appropriate next step. The choices are: Broaden the antibiotics to a different class. Drain the obstructed, infected kidney urgently. Repeat blood cultures and continue observing, or schedule stone removal in the next few days. Here is the key insight to hold on to. He is already on antibiotics and fluids and is not getting better. Ask yourself what the antibiotics cannot reach and predict your answer before we walk through it. Let us break this one down. Read the trigger words first. The phrases that matter are that the patient already received antibiotics and fluids 2 hours ago and is still not improving, and that imaging shows an obstructed, infected kidney sitting behind a stone. That combination is the exam telling you in plain language that antibiotics alone cannot fix this. A blocked, infected system is a walled-off source of infection, and the medicines simply cannot get in to clear it. The cure is to physically drain it. Urgent drainage of that obstructed kidney is what we mean by source control, so our answer is B. Now eliminate the others. Choice A, broadening the antibiotics to a different class, keeps treating around the problem when the real issue is that no antibiotic can reach a trapped infection. Choice C, repeating cultures and observing, simply wastes time while the patient stays in shock. Choice D, scheduling stone removal in a few days, is actually the right procedure, but at the wrong speed, because an infected obstruction in a septic patient is a true emergency that cannot wait. So remember the lesson. When a patient on appropriate antibiotics is not improving, hunt for a source that needs to be drained or removed. The correct answer is B. Our third question takes us to the moment where the first round of treatment is done and the patient is still in trouble. A 60-year-old woman with a urinary tract infection is admitted with sepsis. She has already received broad antibiotics, blood cultures were drawn, and she has been given 30 milliliters per kilogram of balanced crystalloid fluid, which is the standard generous starting amount. Despite all that, her blood pressure is still 78/40, her mean pressure is 52, and her lactate is still high. The question asks for the most appropriate next step. The choices are: start norepinephrine to support the blood pressure, start dopamine to support the blood pressure, give several more liters of fluid and reassess later, or start a stress dose steroid as the next single step. Here is your cue. She has had adequate fluids and is still hypotensive, which is the very definition of septic shock. Predict which blood pressure medication comes first, and we will walk through it on the next slide. Here is the breakdown. First, match the stage to the step. This patient has already received adequate fluids, the full generous starting amount, and she is still hypertensive with a high lactate. That combination, persistent low pressure after enough fluid, is the very definition of septic shock. The step that matches that stage is a blood pressure medication, and the first-line agent in septic shock is norepinephrine. So the answer is A. Now the vasopressor pearl, and this is where the wrong answers teach you the most. Choice B. Dopamine is a classic trap. It can raise the pressure, but it causes more abnormal heart rhythms and is not the first-line choice, so the exam wants you to pass it over. Choice C, giving several more liters of fluid, is risky once you have already given adequate fluids and the pressure has not responded. Drowning the patient in extra fluid does not help and can cause harm. Choice D, the stress dose steroid, is only considered later, after a pressor is already running and the shock is still not improving. It is not the next single step here. So lock in the sequence the exam loves. Norepinephrine first, and then add vasopressin if one drug is not holding the pressure. The correct answer is A. Let us wrap up. First, study smart. Lean on your question bank, your favorite board review book, and a trusted management reference for the actual content. Then drill sepsis cases over and over until two things feel completely automatic: recognizing the syndrome and running the first hour bundle. When the pattern jumps out at you instantly, these questions become some of the most reliable points on the whole exam. Second, practice the strategy until it is second nature. Read the last line of the question first, stage the patient as infection, sepsis, or septic shock, predict the next step before you look at the choices, and eliminate the wrong options by mechanism. Keep the management order in your head: cultures and lactate, then antibiotics and fluids, then reassess and add a pressor. Every sepsis question rewards that same rhythm. If this video helped you, please like and subscribe for more board review content. And when you are ready for personalized help, visit roadmaptoresidency.com, where our expert tutors and residency advisors are ready to guide you. Good luck on your exam. You have got this.